Good morning, good afternoon, good evening, ladies and gentlemen, colleagues and friends, to this fourth webinar on heart and vascular disease from the Cleveland Clinic Foundation. You will get a good overview about valvular heart disease, and I would like to introduce the first two speakers to this session. You will see from the program that we always have two speakers giving their talk, and after the talk we have a 10-minute discussion, and in the end we will have an even longer discussion to address questions which have arisen from the talks. So the first two speakers, the first one will be Dr. Idris. Dr. Idris is a cardiologist and working at the Cleveland Clinic Abu Dhabi. He will talk about low-risk aortic stenosis, TAVR versus SAVR. And the second speaker will be Professor Prendergast from the Cleveland Clinic in London, and he will talk about aortic stenosis with complex coronary artery disease and what is the optimal treatment option. Enjoy the talks.
Hi, my name is Ahmed Idris. I'm an interventional cardiologist at Cleveland Clinic Abu Dhabi, and I'm going to be discussing a case of low-risk aortic stenosis. Thank you for giving me the opportunity to discuss today. I have no disclosures of financial interest. Now, I chose a case of bicuspid aortic valve disease because I think this is becoming a more important issue as we treat lower risk patients with transcatheter aortic valve replacement. Younger patients who are low risk inherently have a higher prevalence of bicuspid anatomy. And I think addressing this in the future is going to be very important as we go forward with this technology. So let me begin with this case presentation. It's a 67-year-old male with a history of non-ischemic cardiomyopathy and recurrent congestive heart failure requiring hospitalization despite compliance with optimal medical therapy. He is known to have a severely dilated left ventricle and noted to have significant aortic valve stenosis, and he was referred to us for our further evaluation. His exam was significant for a late peaking systolic ejection murmur. His baseline ECG showed a sinus rhythm with evidence of left ventricular hypertrophy and secondary repolarization abnormality. His echocardiogram, if you look on the left side of the screen, is a parasternal long axis view, shows a severely dilated left ventricle with significantly reduced left ventricular systolic function. His aortic valve is restricted in motion, calcified. And on the right side, in the short axis view, you get a sense that this is a bicuspid aortic valve. Interestingly, despite having an EF of 25%, his mean gradient across the valve is 54, and this screen is as high as 57 measured. So you can imagine that if he had normal LV function, that his gradient would be much higher. A CT cardiac angiogram was obtained, and here you can see on the right side of the screen a type 0 bicuspid aortic valve with calcium involving one of the leaflets more than the other. There's no RAFI, there's no other calcifications noted in the subvalvular apparatus. Now you can see here the annulus measures about 25 by 35 millimeters, very eccentric. The area is 680 millimeters squared. It's important that right coronary and left coronary heights were very high at 20 millimeters each. This is a summary slide that we use for our heart team discussions, and we also have this displayed during our cases. I think it's important to have the data summarized for us, not only for the heart team discussion, but also during the procedure itself. It's nice to refer back to. But here you can see the bottom left corner, the laboratory data showing normal kidney function and normal hematocrit. His echocardiogram again shows the high mean gradient with an EF of 25% and no other significant valve disease. His cardiac catheterization was performed showing no evidence of significant coronary disease. He was a very good transfemoral candidate with good large right and left femoral arteries. His coronary heights again were high, and there's no other real high risk features. Now, despite having an advanced cardiomyopathy and low EF and recurrent heart failure, his STS calculates at 1.163% for this young 67-year-old male. So I think it's important to know that the initial obstacles and complications encountered with TAVR have been addressed and have led to steady improvements in outcomes. And this is largely due to patient selection. There's better patient selection now than there was in the earlier, of course, clinical trials, particularly in the PARTNER 1 trials. Of course, there's more meticulous procedural planning using multimodality imaging with MDCT becoming the standard of care. Device development leading to fewer complications is important. The devices are more flexible, they're smaller in profile, they're more deliverable. These have led to steady improvements. And accumulating operator and site experience is important, not only physician experience, but also team building, team physician, team experience is important in these outcomes. And this has resulted in the expansion of TAVR to lower risk patients. And so again, the discussion is no longer about SAVR versus TAVR, but rather appropriate patient selection and individualizing the right therapy for each patient. We know that TAVR in elevated risk patients, those with moderate or high risk for surgical aortic valve replacement, has been well demonstrated in large-scale randomized clinical trials. And this led to studies in low-risk populations. You can see here, partner 3 in balloon expandable valves on the left side, and self-expanding valves studied in Evolut low-risk trials on the right side. And you can see that TAVR, compared to surgery, was deemed to be non-inferior in terms of the primary endpoint in both these trials, really opening the kind of floodgates for the treatment of patients with low risk anatomy and also low risk for surgical aortic valve replacement. But it's very important to understand that these trials were performed at high volume expert centers, and it's not exactly sure that these same outcomes will be transferred to centers who have lower experience or lower volume. It is also important to understand the exclusion criteria of these trials. The low-risk trials excluded bicuspid valve anatomy. They also excluded any other severe valvular disease or significant ventricular dysfunction that our patient has. They excluded complex coronary disease or any other pre-existing surgical valves. So these exclusion criteria are important when we're considering these, applying these data to outcomes in our low-risk population. And bicuspid aortic stenosis is not included in any of the pivotal randomized clinical trials. And that's because there's several unfavorable features of bicuspid aortic valve anatomy that people need to understand. One is the annulus is more elliptical, of course. There's asymmetric calcium distribution, which may lead to higher degrees of paravalvular regurgitation. There's also oftentimes bulky calcification extending to the LVOT, which may lead to annular rupture, particularly with balloon expandable valves. There's oftentimes lower coronary heights and ascending aortic dilatation that may lead to aortic dissection. And so when you look at this small registry, about 560 patients, where they looked at bicuspid aortic stenosis compared to a propensity matched cohort, about 4,500 patients, looking at all-cause mortality, there was no difference between the two groups. But if you look at the rates of conversion to surgery were higher in the bicuspid aortic stenosis group. There was a higher degree of aortic root injury. There was a higher degree of moderate or severe paravalvular regurgitation in the bicuspid aortic cohort, and device success was also lower in the bicuspid group. In this more robust TVT registry, looking at almost 2,700 propensity score matched pairs of bicuspid and tricuspid aortic stenosis, again, the median age is about 74, STS about 4.9%. The all-cause mortality was no different, and neither was stroke at long-term follow-up, but stroke at 30 days or peri-procedure stroke was higher in the bicuspid aortic stenosis patients. I think these are important caveats to understand before subjecting low-risk patients who are good candidates for surgical aortic valve replacement to TAVR. But I do understand there's significant variability in bicuspid aortic valve stenosis, particularly with leaflet and RAFI calcification. If you look at the middle group, which is a Seaver type 1 classification, bicommissural RAFI type, which is the most common type of bicuspid aortic valve, there's huge variability in degree of calcification involving a leaflet and the RAFI themselves. So although patients with a very mild leaflet calcification and no RAFI calcification may be favorable candidates for bicuspid aortic valve, TAVR and bicuspid aortic valve, patients with excessive leaflet calcification and excessive calcified leaflet may be unfavorable anatomy for bicuspid aortic valve TAVR. And so I really like this registry, which is very well done. It looked at 1,034 CT-confirmed bicuspid aortic stenosis patients. The mean age was 74.7. The STS was 3.7%, who underwent transcatheter aortic valve replacement. The majority of these patients underwent SAPIEN 3 or balloon expandable valve, about 740 patients. 133 underwent Evolut R Pro, self-expanding valves, and 106 were other valves. And again, the majority of these patients were latest generation devices. And they divided the groups in terms of patients who had no calcified raphe or excess leaflet calcification, and those who had either of them, or patients who had both calcified raphe plus excess leaflet calcification. And they found that patients who had calcified raphe and excessive leaflet calcification had the highest all-cause mortality, significantly more than the patients that did not. In fact, those with calcified raphe and excess leaflet calcification have higher degrees of paravalvular regurgitation that is greater than moderate, a higher degree of aortic root injury in this study, and a higher all-cause mortality at 30 days. So I think it's very important to really select the correct phenotype for bicuspid valve if this is going to be even considered in a low-risk population. But again, I think without large-scale randomized data, it's very hard to recommend this across the board. The other aspect I think to understand is that the paravalvular regurgitation degree is very important. Those who have moderate or higher degrees of paravalvular regurgitation are going to have worse outcomes. And this is going to be more important in patients who are younger, who are lower risk with longer life expectancy and longer exposure to this. And we don't really understand what mild paravalvular regurgitation has on over the long run for patients with very long life expectancies. In fact, if you look at the PARTNER 3 and Evolut low risk trials, they reported that a significantly higher rate of mild paravalvular regurgitation in the TAVR arm compared to the SAVR arm, up to 30%. And again, I don't know what this means for long-term prognosis for these patients. Now, we know from echocardiographic assessment, whether it's TE guided or transthoracic echocardiographic endometers, often underestimates the severity of paravalvular regurgitation, mainly due to posterior attenuation. And so at least in our lab, we've moved away from just using imaging. We've combined all three modalities. We combine echocardiographic assessment, typically transthoracic, with hemodynamic assessment in every single patient pre and post. And also almost every patient gets aortography to really assess paravalvular regurgitation. And we try to have every single one of our patients leave our lab with trivial or less paravalvular regurgitation. And we have oftentimes liberal use of balloon post-dilation if needed. The other thing that we have really focused on our lab, because I think this is important for low-risk patients, is pacemaker implantation. We know that that pacemaker implantation is associated with worse all-cause mortality, and it's also associated with significantly greater readmission for heart failure. And so I think, several labs, and ours included, have turned away from using coplanar barrage, using a cusp overlap view for our deployment and our caudal projection to achieve as high of an implant as possible, avoiding the conduction system complications and pacemaker implantation rate. I really like this slide coming out of Cleveland Clinic main campus, and Dr. Kapadia's group really summarizes conventional deployment technique versus the high deployment technique. When you use this ariocaudal view, I'm really looking at this cusp overlap view where the non-coordinate cusp is the lowest point in the annulus, and you can achieve a very high implantation by using this implantation technique. With an exceedingly low pacemaker rate. We switched over to using this method about 2 years ago, and we've had one pacemaker implantation in the last 2 years. So if we go back to the patient who I presented, he was presented to our heart team, and the surgeons felt that he were concerned about his LV dysfunction, his dilated cardiomyopathy that was long-standing, and concerned that he may not have a good outcome with surgical intervention, and felt he may be a better candidate for transcatheter aortic valve replacement. He did have a bicuspid aortic valve, but didn't have calcifications on both leaflets. He had good coronary heights, no subvalvular calcium, no other high-risk anatomy. And so he underwent transcatheter aortic valve replacement using a 29mm CPN3 balloon expandable valve. Here you can see the deployment on the left side, and the final image on the right is showing no significant paravalvular regurgitation and a reasonably high implantation. Post-procedure, his echocardiogram showed no evidence of significant paravalvular regurgitation. Some improvement in his left ventricular systolic function, but this is very modest. His mean gradient post-procedure was only 9mm of mercury, which is expected. His post-procedure ECG, again, no evidence of significant change, no evidence of pacemaker requirement. So to summarize, bicuspid aortic stenosis has a higher prevalence in younger low-risk patients with severe aortic stenosis, and will be an important issue to address as the technology develops in the future and we treat more low-risk patients. TAVR and bicuspid aortic stenosis has been excluded from all pivotal randomized trials, with only registry data showing reasonable outcomes in appropriately selected patients. That is, patients we try to avoid with heavily calcified leaflets and raphe, and those with high-risk anatomy, for instance, low coronary height or subvalvular alveolar calcium. The recommendation will continue to be SAVR, or surgical aortic valve replacement, in young patients with bicuspid aortic stenosis with low surgical risk. These patients have a longer life expectancy, and we have to guarantee an excellent result in this group. And paravalvular regurgitation and pacemaker implantation have important consequences for patients with longer expected life expectancy. So I'll end with that, and thank you very much for your attention.
Thank you for asking me to join you for this evening's webinar. It's a great thrill to be with you and to be part of the worldwide Cleveland Clinic family. My name is Bernard Prendergast, and I work at St. Thomas's Hospital and the Cleveland Clinic in London. And this evening I want to talk to you about the difficult combination of aortic stenosis with coronary artery disease and optimal treatment options for this combination in 2021. Aortic stenosis and coronary artery disease share the same biochemical messages and the same pathophysiology. And the conditions coexist in up to 60% of patients. Unlike coronary artery disease, however, aortic stenosis is inexorably and inevitably progressive and associated with inevitable accompanying morbidity and mortality over time. And this progression of disease is very adversely influenced by the presence or coexistence of calcification, which of course is shared with the pathophysiology of aortic stenosis. Disappointingly, attempts at medical management directed at both coronary artery disease and aortic stenosis have failed miserably, as demonstrated by this large randomized controlled trial conducted in Edinburgh, UK, addressing, for example, the role of statins in slowing the progression of aortic stenosis. And as we address treatment options in these patients, we need to think beyond medical therapy and address the optimal mode of revascularization, whether that's achieved by means of transcatheter techniques, PCI with TAVI, or by means of surgery, surgical aortic valve replacement, in conjunction with coronary artery bypass grafting. And a fundamental premise that I want to emphasize alongside other speakers in this symposium this evening is the essential role of the heart team in determining the management strategy for individual patients. A recommendation that was endorsed very strongly by the recent ACC AHA guidelines document published just before the turn of the year, and also opening up and widening indications for TAVI in younger and younger patients, in whom the coexistence of coronary artery disease may be a very realistic and very major contributor to their overall long-term prognosis. The first message I want to get across beyond heart team is that TAVI is not always the answer in patients with aortic stenosis. And I say that, of course, with my own personal conflict of interest as an interventional cardiologist. We do need to remember that aortic stenosis is a well-established treatment, aortic valve replacement is a well-established treatment option for aortic stenosis, and that surgery remains a very, very good option for many, many patients, particularly those with more complex manifestations of coronary artery disease, those with a bicuspid aortic valve, and those with accompanying aortopathy, particularly affecting those with bicuspid aortic valve pathology. TAVI is with us, however, and consuming a greater and greater proportion of patients with aortic stenosis as we move into the 21st century. And the concept of PCI as an adjunctive treatment for these patients is very much a reality in everyday clinical decision making. But we do need to remember that PCI has particular hazards in this patient cohort. The majority of patients undergoing TAVI remain elderly and frail and have important comorbidities, particularly renal failure, peripheral vascular disease, and anemia that may make angioplasty in conjunction with stent implantation potentially risky, both in the immediate procedural term and in the longer term post-procedural course. Secondly, the procedures themselves may be challenging, either by virtue of dilation and tortuosity of the aortic roots, which may make access and guide catheter support challenging. And secondly, the coronary arteries themselves, which are frequently calcified and diffusely diseased, presenting challenges for even the most experienced interventionist. Finally, angioplasty in this setting may be associated with hemodynamic instability as a consequence of the aortic stenosis, and the interventionist needs to be prepared to consider the option of a concomitant balloon aortic valvuloplasty at the same sitting. There are also important questions in relation to the timing of angioplasty in relation to TAVI, or TAVR as you call it in the US and wider world. PCI before the TAVR procedure can potentially reduce the procedural risk of the ensuing aortic valve intervention. It will clearly abolish the need for a secondary revascularization procedure following the TAVR. But do remember that dual antiplatelet therapy may increase the risk of bleeding complications at the time of the TAVR procedure. A concomitant procedure, PCI at the time of TAVI, is clearly attractive for many reasons. It uses resources efficiently, it's convenient for the patient, and it provides a single mode of vascular access, allowing both procedures to be performed. But this in itself may not be without hazard. And finally, if we contemplate PCI following a TAVR procedure, we need to recognize that relief of aortic stenosis may in fact abolish ischemia and make the patient angina-free and asymptomatic. We need to recognize that reducing myocardial oxygen demand by relieving aortic stenosis before the angioplasty may reduce the risk of PCI-related complications. But we also need to recognize that performing the procedure when a TAVR valve is in situ invokes a whole new set of procedural challenges which are listed here. And these challenges are more marked, of course, with longer TAVI devices, typically those which are delivered by self-expanding technology. And in the final part of my talk, I want to present to you some new breaking data, which were actually presented by Simon Redwood, my colleague, at the PCR Valves e-course last November, and which are currently under review for publication in the Journal of the American College of Cardiology. The activation trial addressing the pros and cons of angioplasty in the setting of TAVI recipients. This is a prospective multi-center trial undertaken at 17 sites in Europe, randomizing patients with aortic stenosis and significant coronary artery disease to TAVI alone or TAVI in conjunction with an angioplasty procedure. Patients were followed up for 1 year for the endpoint of all-cause mortality or rehospitalization, with numerous important secondary outcomes relating to cardiovascular and non-cardiovascular events, particularly bleeding. The inclusion and exclusion criteria are summarized on this slide. Essentially, these were adults with severe aortic stenosis, significant coronary artery disease and symptoms relating to their aortic stenosis, and angina in Canadian class 2 or 3. We were able to enroll almost 240 patients in this trial, and their baseline characteristics are summarized on this slide. Consistent with UK practice and European practice at the time of enrollment, most patients were in their 80s. 2/3 of them were male. And as you can see, the inclusion criteria specifying relatively moderate angina were met in the vast majority of patients. And these patients were predominantly in an intermediate risk category. The details of their coronary artery disease are summarized here. You can see that 60% of patients had LAD disease, with circumflex and right coronary artery disease distributed equally. And you can see that single or two vessel angioplasty was contemplated in the vast majority of subjects. The primary outcome is demonstrated here in tabular format, indicating the lack of any statistical difference between the study arms, and also perhaps more clearly pictorially represented here with the Kaplan-Meier curves clearly demonstrating no advantage of performing angioplasty as an adjunct to TAVI in this patient cohort. Indeed, if we look at secondary endpoints and notably bleeding events highlighted here, you can see that there was an excess of bleeding events in the PCI arm of this study, related no doubt to the need for dual antiplatelet therapy in this relatively elderly cohort. So in summary, in this brief presentation, and I am of course happy to join the panel for discussion and questions as part of this session, I want you to leave you with the message that coronary artery disease and severe aortic stenosis commonly coexist and confer adverse prognosis. Medical treatment, unlike stable coronary artery disease, has a limited role in the setting of aortic stenosis, since medication has no ability to hinder the progression of this serious disease with associated morbidity and mortality. Please do remember that surgical aortic valve replacement is a very important treatment option in this setting, and that the conjunctive treatment with coronary artery bypass surgery is a very good option in many patients, particularly those who are young, those with a bicuspid valve, those with associated aortopathy, and those with complex coronary artery disease, as demonstrated in the SIR-TAVI trial with a threshold syntax score of 22. In the real world, however, many patients and investigators are drawn to the combined treatment of angioplasty in conjunction with TAVI, and this, of course, is a particularly appealing option in older, intermediate and high-risk patients who still form the majority of patients being referred for the TAVI procedure. And finally, I've been very pleased and proud to present the activation trial data, which we hope to see published soon, the first randomized trial of angioplasty versus a conservative coronary treatment strategy for patients with severe AS and coronary artery disease, suggesting that a conservative approach may be more appropriate in a large proportion of our patients. Thank you for listening.
Well, thank you very much, Ahmed and Bernard, for your comprehensive overviews on the two topics. I would just like to welcome all the listeners to the webinar to join us in asking questions on the electronic system. And but before the first questions come in, I would like to ask one to Dr. Idris beforehand. So you nicely showed that there is new evidence on how even in bicuspid aortic valve disease TAVR can be used to treat patients. You presented a patient of 67 years of age. You said in your talk there was less of a question of SAVR versus TAVR because of risk of patients. Do you think there is enough evidence for young patients in terms of long-term prognosis of TAVR devices?
I chose this bicuspid valve patient particularly because I think in the UAE, I think younger patients are hearing about TAVR and they're reluctant to do surgery. And I wanted to emphasize that not all patients are the same and that there's a really good treatment option with TAVR. I don't think we have long-term data yet, of course, on low-risk population. And I think that will establish the true role of TAVR in the long run. And it's even especially more true for bicuspid anatomies where there's really no randomized data, only registry data. And so I kind of wanted to emphasize that again, not all patients are the same, not all bicuspids are the same. And we should try to, push for surgical aortic valve replacement in these population as a first line, and then TAVR as a second line if they have higher risk for surgery.
And maybe we move a little bit in direction from leaving the younger patients comparing mortality against each other, but comparing morbidity against each other, as you have done in your talk when you came to power leakage and pacemakers and so on, right?
That's good. I think these are not inconsequential issues. And paravalvular regurgitation, pacemaker have life-altering issues, particularly for mortality and morbidity.
Yeah.
So one of the questions is, just for the discussion sake point, that what we are talking these days with a lot of patients, bicuspid or not, when they are younger, is the lifetime management of AS.
Mhm.
So when you are talking about the aortic valve, whether you put a surgical aortic valve or whether you put a transcatheter aortic valve, what would be the next step? Is it going to be a small size surgical valve? Is a large size surgical valve? Is a small, is the TAVR valve such that we will be able to put a valve in valve? What are the size of sinuses? What is the height of the STJ? So my point of saying all this is that anatomy is the most important variable in deciding what should be what is the way of lifetime management. So in the past, we thought about the risk. So low risk, intermediate risk, high risk surgical patient. This is, I think, thinking of the past. These days, what we look for is to say that what is the anatomical solution for this problem? And if this solution is going to be how we are going to manage the solution in the lifetime of the patient. So if we have a good answer to that, then I think everything else falls in place. So anatomical risk characterization requires experts in both fields, so surgery as well as in cardiology. So again, the management becomes like all our TAVR meetings now are related to anatomy. It is not related to the risk. So we are looking at the CAT scans together. We are trying to understand, and CT scan, by the way, is the best way to look at the anatomy. So it has come to a simple method of deciding what is the best treatment for aortic stenosis is to look at the anatomy with CAT scan.
We have not much more time left, but Bernard, this taking into account the age of patients and lifetime strategy, do you think that is also a particular kind of point we need to address when one has combined disease of aortic valve and coronary arteries?
I think that's exactly right, Olaf, and I agree entirely with everything that Samir has said about anatomy. And of course, anatomy extends beyond the CT scan and the aorta, but also to encompass the coronary anatomy. So if you've got a type A lesion in a large OM and a mid-LAD, and the patient is anatomically suitable for a TAVI, then go for it and offer them a transcatheter option, probably in one sitting. But if they've got an LAD occlusion, a complex bifurcation of the OM circ, and a nasty right coronary lesion with a syntax score of 28, let's say, then arguably surgery with bypass surgery is a better option, a better solution. And it's bringing these mature discussions together in a heart team setting that will identify the unique approach for each patient. That has to be the direction of travel.
And from the surgical point of view, I would completely agree with that. The only addition I would make is that one should also look at the clinical presentation of the patient, because we all know there are 70-years who come in a wheelchair to your first consultation, and there are 85-year-olds who come to you with complaints about not being able to play 18 holes of golf any longer. So I think this, in addition to anatomy, I think I would be, from the surgical point of view, completely agree with.
I have one brief question. That do you think that you think about coronary artery disease any different if it is with aortic stenosis, or just think about coronary artery disease that you would think about with or without aortic stenosis? So of course, I want to know your answer. My personal answer is that I don't think anything differently. So if you are going to say aortic stenosis and coronary disease, treat as you would have otherwise treated the coronary disease.
So I agree with you, Samir, and I think the results of activation support that. You know, if you've got minimal or no angina, you don't need to put in a stent.
Correct.
And, you know, equally, you can give the patient a TAVI and assess them 3 months down the track. And if they've still got angina, you can bring them back for a straightforward angioplasty procedure. So I think you're right that we need to consider the algorithm for coronary disease has to be very similar to coronary disease in isolation as it is with coronary disease in conjunction with aortic stenosis.
And Olaf, you know, if you wanted to put a surgical valve and if there is a OM lesion, which is 70%, it may be worthwhile to leave it alone and just rather than put a vein graft and do the aortic valve replacement. That is not totally unreasonable also. And this is of course a difficult question because you are going to do a mini AVR versus if you have to do an open, a full sternotomy.
Well, I would say yes and no. I mean, as surgeons, we also know about all the investigations done in the past, and there was always a focus on 5-year outcomes after aortic valve treatment on its own or in combination with coronary arteries. And you have shown one nice thing from the activation trial, and that is not only that it worked in the way of same survival, but you also showed that the main complication were bleeding problems. You do not have that problem with surgery, as you know, because you do not need to do antiplatelet therapy. And that is the reason why I would say I would in principle address coronary arteries at the same time, as long as it does not increase the morbidity, mortality of the patient for the procedure. And in experienced hands, as you know, bypass surgery in addition to the valve doesn't make a big difference. So I would say I would be maybe a little bit more liberal to leave coronary arteries if I'm forced to because of other reasons. But on the other hand, I think the morbidity risk of addressing coronary arteries at the same time is different than it is after PCI.
Wonderful. Thank you again, everybody. Any other questions? I don't see much questions coming from the audience, but feel free to ask us questions. Otherwise, we can move on to the next group of talks. So, Dr. Bhatnagar is going to talk about the endocarditis, surgical indications and timing. Dr. Bhatnagar is the chief of cardiac surgery at Abu Dhabi, very accomplished surgeon and very experienced in this particular field of endocarditis. This is one of the most important newer area for surgical treatments because there is really no percutaneous treatments there. So this is an important part, and especially also with the transcatheter valve endocarditis, there is a large need. So we are excited to hear about the endocarditis treatments. And the next talk, go ahead, Dr. Bhatnagar, and then we'll introduce the next talk after.
Good evening, everybody, to the webinar series this evening. It's Dr. Gopal Bhatnagar. I have no disclosures or conflicts of interest to declare. This evening, we're going to be talking about the surgical indications for endocarditis. And our objective will be to identify the primary indications for urgent surgical intervention, to know the indications for surgical interventions in a more chronic phase, and we'll discuss some key considerations for surgical interventions, including post-cerebral embolism or hemorrhage, culture-negative endocarditis, fungal infections, and right-sided endocarditis. And we'll cover valve vitals. Of course, giving the talk at the Cleveland Clinic is always intimidating, and the guidelines, in fact, were written by august members of our main campus staff. It's important to create an optimal ecosystem when we're dealing with these patients that can be quite sick with multiple comorbidities, and cardiovascular medicine and surgery, as well as infectious disease and neurology, often have to work together, including in the ICU team, to get these patients through. It is important to point out that local tissue destruction and reconstruction can be technically very challenging, and the surgical team themselves ideally should be well trained and experienced in valve surgery. There's quite a number of individual criteria. I will not go through each one. However, if we take a look at some highlighted ones, we're going to take patients urgently to surgery that have valve dysfunction and symptoms of heart failure, severe aortic insufficiency or mitral regurgitation with medically intractable heart failure, once we load them with antibiotics, should be taken to surgery. We also have patients that have left-sided endocarditis caused by Staph aureus or fungus or highly resistant organisms, as these can cause a lot of local tissue destruction, Staph aureus itself being very destructive. Patients in their initial hospitalization should be considered if they have progressive heart block, evidence of annular or aortic abscess, and evidence of destructive penetrating lesions such as fistula into the atrium or ventricle. Also, patients that have persistent sepsis that cannot be controlled and is related to the intracardiac infection should also be considered for surgery. Often patients with tricuspid infections may have ongoing sepsis related to lung abscesses. This can produce quite a conundrum diagnostically and therapeutically. Covering the size of vegetation and risk of embolization, that is considered one of the indications, and we have clear evidence that the larger the vegetation, being cut off at 10 millimeters, the higher the risk of embolization, and we see adverse outcomes at vegetation size of 10 millimeters of 25% versus 10%. And then certainly when vegetation start increasing to 15 millimeters or beyond, the risk of embolization rises dramatically. Many patients will present initially with a neurologic event, and up to 44% of patients will have evidence of neurologic events on cerebral imaging. After ischemic infarction, studies have shown that neurological complications due to cardiac surgery declines over the first month, about 20% in the first 3 days, and at about 14 days down to 6 to 10%, and after 28 days following index presentation, only about 1%. Small silent infarcts without hemorrhagic conversion can safely be operated on within the first 3 days. If there's significant hemorrhagic conversion, then these can offer quite a prohibitive risk to surgery conventionally, and should wait up to 4 weeks or beyond if possible. Of course, mitigating clinical circumstances may require surgery before that time, but we know that the risk of deteriorating neurological function remains high. I'd like to cover the indications and the nature of surgery valve by valve, and we'll start with the aortic valve and the aortic root. The general indications for surgery are, as previously mentioned, we have evidence of abscess formation, conduction or imaging evidence, Staph aureus bacteriology, pseudoaneurysm formation, as well as progressive paravalvular leak with a prosthetic valve. The choice of prostheses is often discussed, but the most important thing is really the surgical principles: radical debridement of infected tissue, reconstruction of anatomy, and the implantation of prostheses in healthy, strong tissue. Repair is rarely possible, and the use of topical antibiotic solutions is common practice, but not independently supported by the evidence. There's really, if we take a look at biological versus mechanical valves, age by age, the incidence of mitral reoperation in patients that have younger than the age of 50, having a biological valve will remain high. Patients that over 50 that have a biological or mechanical valve really have no difference in the outcome, either in reoperation. Homographs have been extensively utilized in the aortic root, but when looking over a period of time, in this paper published just recently in the Annals, we take a look at the long-term survival following homographs in the aortic root was less than stellar, and there have really been no differences in the change in recurrent infections, which as previously thought. So if we take a look at these two studies, Kaplan-Meier and actuarial survival, whether there's a bioprosthetic or mechanical valve replacements, there's no difference in the evidence of recurrent endocarditis. However, just going back technically, it can be a very challenging procedure. This is just something that was published by our group here, using the freestyle valve to reconstruct a completely destroyed aortic root. Often tissue integrity is quite diminished, and whether pericardium is used to reconstruct the aortomitral and aortoventricular continuity is up to the surgeon's discretion. However, we found that the freestyle valve is a flexible biobentol. This has been inverted into the ventricle so that the margins are clearly seen, and this can be placed more inferiorly into healthy tissue, avoiding the need for completely circumspect annular reconstruction. The tricuspid valve can often be repaired, and ideally so, debridement of infected tissue with a pericardial patch and cortex neocords. Vegetectomy and, in fact, valvectomy has often been advocated in patients who have a history of drug abuse. However, these are often poorly tolerated, and we see that the odds ratio for operative mortality do increase, and patients often are very debilitated after surgery. So trying to repair and give some evidence of a functional tricuspid valve is of benefit. In patients with mitral endocarditis, take a look in here, these patients actually were advocated for early surgery. 33% of CVAs were asymptomatic, however, in this, and it was found that reinforces the thought that small lesions that are asymptomatic without hemorrhagic conversion can be operated on. Mitral valve gives us the option of repair, fortunately. If we were to take a look at patients that had repair versus replacement, these were not randomized to repair versus replacement, but repair whenever feasible. We can say that the long-term outcome is actually quite reasonable. It's actually good in patients that have had repair. Now, the repair depends, of course, on the experience of the surgical staff, the individual surgeon, as well as whatever tissue is left undestructed. So it advocates for earlier operation in patients with mitral endocarditis, if it's all feasible, so that there's less tissue destruction, more native tissue to work with, and the ability to repair that valve. You can see the overall survival in this paper from the European Journal with repair was better, even long-term, in patients. Once again, the pitfalls here is that it's not really obviously randomizable, but really making the argument that if repair is possible, that recurrent infection is not a major problem and long-term outcome is sustained. In summary, once the diagnosis of endocarditis is established, surgery should proceed without delay, provided indications are met. Neurological sequelae are common and may be silent, indicating brain imaging and vascular contrast as indicated when at all possible. But cerebral hemorrhage, waiting 4 weeks if clinically possible, remains the guideline standard. New information is evolving, suggesting that early surgery may be safe even if bleed is limited. The surgery team should be part of a multidisciplinary care team involving cardiovascular medicine, infectious disease, and a full medical ecosystem needs to be developed to optimize the outcome. Surgical team must also be well experienced in reconstructive techniques of the annulus of the aorta as well as mitral valve, so that full surgical debridement can be done without compromise. Selection of prostheses is secondary to good debridement and reconstruction in determining the outcome of patients, but the surgical trend has been towards a greater use of tissue valves. Thank you very much for your attention this evening.
Hello, everybody. Great presentation, Gopal. And now we are going to move to a next talk, which is by Dr. Lars Svensson, who is the chairman of Heart and Vascular Institute at Cleveland Clinic in Cleveland. He is a world-renowned surgeon for aorta and aortic valve, and he's going to talk about the asymptomatic severe aortic stenosis, whether we can wait and watch or whether we should do valve replacement. Dr. Svensson.
Hello, here from the Cleveland Clinic, main campus in Cleveland, Ohio, and I look forward to chatting to you, and it's great to have this global meeting that Mira Tuzu and the team kindly put together. So I was asked to talk about asymptomatic aortic valve stenosis, but I'll touch on a couple of other things and also give some background to what we do on main campus. This is a sort of problem we deal with. If you look over here, there's already a ascending tube graft sewn into position and a patient with severe stenosis and a bicuspid valve. And as we'll discuss, some of these patients do not have actual symptoms as indications for surgery. In this particular patient, the aorta was the biggest reason for surgery. So last year, our volume of adult cardiac surgery declined somewhat in 2020 with COVID to 4,700 here in the Cleveland area. But over time, our mortality rate has continued to decline, and this is all comers for both adult and cardiac surgery to about 1% for both categories. So to give you an idea of what we do, isolated CABG has increased slightly to 22% now. Aortas are 22%, and the rest are various valve types that we do. And of the valves, most of them are combination valves at the time of surgery. And the results of our isolated AVRs and mitral valves have been very good. And you see the others there. We haven't had a death from a mitral valve repair since September of 2014. And here's our more recent AVR mortality rate, and we had one last year, but very good results. Another point to make is that the risk of reoperation at the Cleveland Clinic since about 2010 has been equal to that of primary operation, although the long-term survival is slightly worse with the reoperations. So when it comes to the Cleveland Clinic, our expected versus observed mortality rate is much lower than the expected. And here's a decade worth of our treatments. So for isolated aortic valves, a 0.3% mortality rate over time. And just to point out, we've done 4,680 aortic valve repairs, something that is not typically recognized by cardiologists as something that's feasible. Our TAVR team has done a great job with 3,600 patients with a 0.6% risk of death. And if you look at patients over time, the survival is slightly worse over time to 15 years with biologic valves. But for the valves that we can repair, the results are really excellent. The other issue is the durability of these valves with a clot or formation or tearing of the leaflets. And the younger the patient is, the greater the risk of that valve failing over time. And patients over the age of 80, it's very low in our hands. But here's a meta-analysis that was done by our teams. And in powder blue there, you'll notice that the pericardial valve holds up very well long-term. Now, what about TAVR versus SAVR and durability and life expectancy? Well, here's a meta-analysis showing in 3 panels there. In the last panel on the right, that after 40 months, we see a divergence with increase in mortality risk in the patients with TAVR, with a cautionary note that younger patients should probably not have TAVRs until we have better understanding of those patients. The other study that is important is by Perabo, showing here in orange that the SAVR valves have the least risk of structural valve deterioration over time, and even the SAPIEN 3 has a slightly higher risk of deterioration, but it remains to be seen how this will pan out over time. Another point is a paper that we produced in December 2019 with Makar's first author, showing long-term 5-year, well, it's not long-term, it's intermediate-term follow-up, showing again that death is increasing more so in the TAVR patients than SAVR, and the risk of stroke is also increasing over time. And here you see the curves have crossed at about 3.5 years in favor of surgery. And here's also the functional class in the upper panel, which is better with open AVRs over time. And you see also the cancer scale there showing equivalent outcomes. Now, what about the asymptomatic patients with enlarged aorta? Well, we use the cross-sectional area divided by the height and a ratio of 10 as an indication for surgery. And this is in the new guidelines that Catherine Otto is the first author on. And in Centers of Excellence, which is a new concept put into the guidelines, surgery is reasonable with bicuspid valves from 5 centimeters and greater. And that's based on a study that we did that we don't have time to review. But here's what we do: plication of the leaflets and sutures to repair bicuspid valves. Here's a running suture on the leaflet edge, and there you see a nice symmetric valve. Now, what we've found is our more recent operated patients have better long-term durability. Obviously, we don't have as long follow-up in the more recent patients, but the durability is 91% from freedom reoperation at 10 years. Another important point is that we have shown that composite mechanical valves hold up very well, and our valve sparing are holding up very well too, and I'll get back to that. So this is a valve sparing or the reimplantation operation, the way we do it, the modification with the pledgets, and then reimplant the valve. And here's a nice symmetrical valve after reimplantation. So last year we did 1,300 odd aorta operations with a slight decline in the number of reimplantations due to COVID. But as of December last year, we've done 1,113 reimplantations, by far the biggest number in the world. And for elective reimplantations, our mortality rate is 0.12% and 97% freedom from reoperation at 10 years. So what about the new categories if you look at the new paper, there are categories of progression of aortic valve stenosis, and basically asymptomatic patients with a severe aortic valve stenosis and an EF of less than 50%, surgery is indicated. As they point out in the guidelines, the partner and the Medtronic trials were all in symptomatic patients for TAVI or TAVR. And so in the United States, TAVI-TAVR is not approved in patients with asymptomatic aortic valve stenosis. So here's the diagram from the paper. So EF less than 50%, patients having other cardiac surgery, exercise tolerance test with a drop of 10 millimeters of mercury, velocity above 5 meters or BNP 3 times normal is another indication, rapid disease progression and low surgical risk. And then decreasing ejection fractions are indications for surgery with no symptoms. I'm not going to dwell much on the specific guidelines. I'd recommend you look at these. So here's a bit about the stages and dysfunction in asymptomatic patients. So there's a class C1 and C2 category for that. And then we talked about exercise testing a bit. So that's another way to look at patients who have low flow, low gradient with severe AS, and they recommend that that's a reasonable test, although we've gone away from that at the Cleveland Clinic. Also, exercise testing may confirm and induce symptoms in patients. And in patients with severe AS and an ejection fraction of less than 50%, surgery is indicated. As you know, this is an unusual category. Certainly aortic valve regurgitation, we see that, but not so much with stenosis. The other one is with exercise and drop of blood pressure of more than 10 millimeters of mercury during exercise. And then there's a summary here of all the other ones, as we mentioned, velocity more than 5, serum natriuretic peptide, BNP, more than 3 times normal, and then a decline in the valve function over time with a velocity increasing more than 0.3 meters per second per year is another indication, which is an interesting one, which I think adds to our better decision-making in these patients. There's also when patients with ejection fraction less than 50%, less than 80 years and asymptomatic, they talk about TAVI. They also recommend in the paper that patients over the age of 80 should have TAVI. That is not in any publications that I'm aware of that shows that TAVI is better than patients over the age of 80 when compared to SAVR. In fact, 2 days ago, I did an 87-year-old 4-vessel CABG plus aortic valve replacement. And this is something we've been doing for years and very safely so. So that is something that I'm not sure why they said over the age of 80 patients should have TAVI. We talked about BNP and the summary there for the other reasons in progression in asymptomatic patients. Just touching on aortic valve regurgitation, the ones that are of note, obviously symptomatic, but a lot of patients aren't symptomatic. EF less than 55%, which I find is not an infrequent indication. And then dilatation of the left ventricle with a LV end systolic diameter of more than 50. You can index that to the patient's height or square meters body surface area, and then also evidence of progression over time and another indication for surgery. I think in this category, the use of an end diastolic size more than 65 is pretty conservative. There's a diagram, an algorithm for women with mechanical valves and how to manage those. We won't go into that. As you know, the data is very mixed on the risk of warfarin and producing neonatal injuries or complications. But the data is very soft, and I don't think I'm convinced in either direction which is better way to go. And then there's also consideration of patients having other procedures and how they should be managed. Obviously, if the patient has significant coronary artery disease, the patient really should have an open surgical procedure with that. Thank you very much for your attention, and appreciate being able to talk to you, and we'll have a discussion later. Thank you very much.
Thank you, Dr. Swenson. It was a great 2 talks. Maybe we can open it up to the panel to try to understand these 2 areas a little bit more in detail. And Dr. Wendler, should be also available. We have a nice panel here, and I'm looking for the questions. And currently there are no clear questions. I will start with a question to Dr. Bhatnagar, that these days when you have the endocarditis patients present, let's say aortic valve endocarditis with a prosthetic valve. So because this is becoming a challenge since we are doing these valves in patients who are very high risk, and we are replacing their aortic valves, for example, and then they come with endocarditis, it becomes very difficult to operate on these patients. What is the method, or what should we consider to do surgically in these patients?
Great question, Dr. Kapadia. I refer to the Forrest Gump movie where redo prosthetic valve endocarditis is like a box of chocolates. You never know what you get until you open it up, so to speak. And I mean, other than the usual precautions of redo that we use here, I've got, and then the challenges of just getting in. Most often with prosthetic valve endocarditis, if you're forced to operate with a valvular leak, and actually excision of the prosthesis is actually very easy compared to one that's well seated. Often that's the easiest part. And then I go back to the same principles of radical surgical debridement. I guess all our surgical careers are sometimes colored by some significant catastrophic events. And I remember implanting stented valves in patients that had very, very destroyed roots, trying to reconstruct them circumferentially with pericardium. And I felt that putting a stent, my own personal feeling has been putting a stented valve in a completely destroyed root is almost creating a situation where you're bending a credit card. There's an inflection point between soft myocardium and a stent and the rigid prostheses. That's why over the last 20 years, I've just preferentially gone to the stentless root replacement. When I've excised the prosthetic valve, usually you have an annulus that is badly destroyed, a lot of disturbed anatomy, and then rather than trying to geometrically reconstruct circumferentially an annulus, the freestyle valve can be placed low down, even into the ventricle. Often the mitral valve leaflet is still intact, then it's flexible, so it moves with the dynamics of the root, and it's very hemostatic. Because one of the problems is not only doing the operation, but often these people, if they're septic, they come off pump very vasodilated and literally in septic shock, and obviously with coagulopathy. So we all have our tricks, and I would say that that's my personal one.
No, wonderful. Dr. Wendler, I wanted to find out from you that Dr. Svensson today is not available for question and answers, but you have any reflection on what, his point of view? Of course, he talked very briefly about the asymptomatic patients with AS, but do you really think that is the early treatment of aortic stenosis any better, or should be considered, or you wait until the symptoms happen?
Well, I think Professor Svensson has very nicely demonstrated the extremely good outcomes the Cleveland Clinic has achieved over all these years. And one, I think, important fact to mention right in the beginning of this discussion is, whenever you want to treat patients who are asymptomatic, they need to face a big risk from their disease, and also, or you need to have extremely good outcomes. So only if you have very good outcomes, you can achieve the prognostic benefit of patients which you would like to achieve in someone who is symptomatically not affected. I think one important point from my point of view is to really define asymptomatic. I see a lot of patients who are referred to me because they have high gradients, and the referring doctor says they're asymptomatic. But actually, when you then have a detailed discussion with the patients, maybe if you even put them on a treadmill test, not necessarily to find out how symptomatic they are from the aortic valve, but to see how much of exercise they can do, they often do not fit into the category of asymptomatic any longer. In terms of
very important point, that they have to be truly asymptomatic.
Yeah.
So I agree with you. And most commonly, at least in the cardiology side, when we see the asymptomatic patients, they have a fair bit of hypertrophy, so the wall stress is less, and that's why they are not feeling symptoms. So the hypertrophy, Tom Mihalovic wrote a nice paper to say that the hypertrophy in itself is a negative predictor for after you replace the aortic valve. So early TAVR is currently ongoing trial where we are trying to study this idea. Of course, the downside in my mind is that whatever valve we put in has a lifetime to it. So if we can strike the balance between not doing it too early versus too late, it is always better. So
let's also not forget the idea of treating asymptomatic patients came out of the fact that asymptomatic patients face the risk of mortality. However, that depends very much how you look after them. If you see them on a more regular basis, if they are coming to your clinics on a regular basis, if you follow them up properly, the risk may be lower. And I agree with you also, it may be quite helpful to gain 1 or 2 years with a patient who is asymptomatic, purely to then put a valve in which lasts to the lifetime, or avoid anticoagulation. So I think it's a multifactorial kind of issue, but I think it will be good to have data on what is TAVR doing in asymptomatic patients, as we know what is surgery doing in asymptomatic patients.
Wonderful. Let us move on, because of the interest of time, to the next session. And next session is going to now focus on mitral valve. We are going to start with Dr. Amar Krishnaswamy, who is the head of our cath lab and also the head of our interventional section of Cleveland Clinic in Cleveland, Ohio. He specializes in structural treatment of valvular heart disease. So Amar is going to talk about the primary mitral regurgitation. Now, this is the current terminology, primary and secondary. So he's going to talk about the primary mitral regurgitation, surgical repair, or percutaneous therapies. Go ahead, Amar.
Thank you very much to Dr. Tunshu and Mahmoud and the rest of the organizers for this wonderful opportunity to be with you together virtually. I look forward to discussing MitraClip for primary mitral regurgitation the current evidence, and future directions. I have no relevant financial disclosures. So what I would like to cover in this talk is to present a case demonstration in MitraClip for DMR. The data supporting surgical mitral valve repair is the gold standard. Place MitraClip data in this context, and then highlight some of the contemporary advances in the MitraClip device and in transesophageal echo imaging, and then discuss the treatment of concomitant tricuspid regurgitation and why that is important. So to start with, this is a 77-year-old gentleman with a prior mechanical aortic valve replacement, atrial fibrillation, and a CRT. He actually had a calculated STS score of 11.4% for a mitral valve repair, which of course signifies quite a high or extreme risk for surgery. You can see here in the left panel, severe mitral valve regurgitation, mild depression in LV function, about 40%. And here you see severe tricuspid valve regurgitation, somewhat near to the RV pacemaker lead that he has. So we brought this patient for a MitraClip. You can see here our routine is to use 3D multiplanar reconstruction imaging in the echo. In the bottom right panel, you see the 3D with the flail A2 segment of the valve and a somewhat retracted posterior leaflet that you can better appreciate with this green imaging plane that takes us to the top left box. And you can see there again the A2 flail, and you also appreciate that the P2 segment there is quite retracted. A little bit tough to say whether that's leaflet extending down below the annulus or in fact just a cord. So you can see here now with the MitraClip in place, if you look at the bottom right panel, again, perhaps the clip is a little bit counterclockwise turned. And also you see a little bit of that retracted P2 leaflet there. And as a result here, you see that there's recurrent mitral valve regurgitation, or as I should say, residual mitral valve regurgitation at that segment. If you look specifically at that area, you can see the red imaging plane, perhaps it doesn't show as well. And then over here in the top right box, you can appreciate that's primarily, if displaced properly, it's primarily just lateral to the clip. So instead, what we can do, especially with this current generation of the MitraClip device, is we simply let go of the leaflets, clockwise the device slightly, and then really swing the device posteriorly so it can independently grasp the posterior leaflet as you see now in the top left box. And then on the right here, once we have swung back anteriorly and grabbed the A2 segment, no mitral regurgitation that's left behind. This patient, as you saw, also had severe tricuspid valve regurgitation. You can see here that the TR primarily originates near the central coaptation, but mostly between the septal and posterior leaflets, as you see in the 3D. So again, in the 3D MPR, what you can appreciate is that we now have a clip inside the right ventricle. In the top right box, you see there it's spanning the septal and posterior coaptation. In the bottom left box, you see there the leaflets are nicely inside the cup of the MitraClip. And once we have grasped the leaflets, really secured those two leaflets, in the top right box, you see a nice tissue bridge between posterior and septal and trivial residual tricuspid valve regurgitation. So we know that surgical mitral valve repair is quite effective. This is a paper more than 20 years old from Cleveland Clinic demonstrating that out to 10 years, almost 93% of patients are free of reoperation. Now, in a more contemporary data set, you can see here that the mortality rate in hospital after mitral valve repair surgery is extremely low. In fact, over the last few years, that rate has actually been 0 for us at Cleveland Clinic. Now, the talk on MitraClip would, of course, not be complete without providing the Everest-2 data, which now was published almost 10 years ago. And what you can appreciate from this trial of all comers randomized to either MitraClip or surgery is that within 1 year, there's a substantially higher rate of needing mitral valve surgery in the clip group, primarily due to severe residual mitral valve regurgitation. That didn't really change too much between years 1 and 4, meaning that those failures were quite early. In fact, most of those failures were even within 6 months. But a really significant limitation of this is that this was the early experience of the MitraClip, people just starting to use the first stage device compared to the standard of therapy, which was surgical mitral valve repair. It's important when we're thinking about surgery for mitral valve regurgitation that we understand the heterogeneity in this treatment. This was an analysis of the STS registry, and you can see here the significant variation in surgical experience. Some surgeons repairing less than 10% of valves, other surgeons repairing 90% of valves. And similarly, the pathology, the type of pathology of the mitral valve is actually quite relevant here. You can see that posterior leaflet pathology, of course, much more effectively treated with repair than anterior leaflet pathology. So all of this data on the MitraClip and Everest-2 really prompted a high-risk study, and you can see here in the Everest-2 high-risk study, those patients treated in blue with a MitraClip in comparison to the dotted red line, which is a medical treatment comparator, did much better. And when added together, the Everest high-risk study and a realism post-Everest registry of high-risk patients, again with an STS score of more than 13%, you can see a substantial reduction in rates of heart failure hospitalization. So both survival is improved and functional quality of life is improved with the MitraClip in these high-risk patients. This is a publication from the TVT registry also a few years ago, looking at over 1,000 patients treated commercially with a MitraClip in the US. Again, a high-risk group of patients, average age of 83 years, STS score of 8 to 10%. And you can see here very acceptable in-hospital and 30-day outcomes with regard to mortality, stroke, bleeding, and so forth. And you can see here that the efficacy was modest of the MitraClip. About 60% of patients had grade 1 mitral regurgitation. About 90% or more had grade 1 or 2, so less than 2+ MR. But we know that residual MR does portend a poorer prognosis, and you can see here that in this same TVT registry, patients left with 2+ MR don't do as well as those with 1+ MR. And just as I showed with the surgical data, there is significant heterogeneity even in the MitraClip experience. You can see in this paper, again from the TVT registry, that frankly, of the 562 operators performing MitraClip analyzed in this paper, less than 50 of them are doing 50 or more, have done 50 or more MitraClips. In fact, the great majority of these operators have done well less than 50. And the reason this is relevant is that you can see here that with regard to experience and considered acceptable procedural success, meaning less than 2+ MR, procedures don't achieve that until they've done about 150 cases or so. And if you're talking about optimal procedural success, meaning less than 1+ MR, that experience up to 200 cases and more is still relevant. If we move on then to the contemporary MitraClip G4, this is really a significant advance. What I'll point out here is that the NT clip is really most similar to that rudimentary device that was used in Everest-2 and the TVT registry data I showed you. But what we have now is we have a wider clip in that same length, the NT, and we also have a longer clip, which is about 3 millimeters longer in terms of the grasping surface, and that also comes in both narrow and wide versions. Further, as I showed you in the case presentation, each of the leaflets, anterior and posterior, can be grasped independently, which really improves our ability to hold on to significant leaflet pathology. The early results of the G4 are not published in any significant fashion. We've only been using the device for about 15 months in very limited centers thus far. But if you look at this paper from Cedars-Sinai, about 59 patients treated with the G4, what you can see here is that only 20% or less than 20% use the initial NT clip, meaning most patients are treated with the more contemporary sizing of that clip. You can see here more than 90% of patients had 1+ MR or less. So again, achieving that optimal success that I showed you in the G4 in the TVT registry. And again, very acceptable safety outcomes. Importantly, we have published a paper here demonstrating the utility of multiplanar reconstruction imaging in these complex cases. This is a patient with a prior mitral valve repair. You can see here extremely lateral MR origin at this ring right out in the commissure, with placing the multiplanar imaging plane, the green there, right out in the lateral corner. You see that leaflet flail of the P1 segment, and with one clip guided by this kind of imaging, trivial residual MR. It's important to note residual tricuspid valve regurgitation is also prognostic. Again, this is from the same TVT registry. You can see that severe residual TR results in worse survival out at 1 year as an independent prognosticator. And we can see from some of the European registries that treating the tricuspid valve regurgitation, in addition to the MR, really these patients do much better with regard to mortality out at 1 year than treating only the mitral valve regurgitation alone. Similarly, for patients treated with isolated tricuspid valve regurgitation, outcome out at 1 year is improved. So to conclude, surgical mitral valve repair certainly demonstrates safety and long-term efficacy. Published results of surgery, however, may not reflect real-world practice, and I think that site individual data is very important. Everest 2 is really a difficult comparator study to surgical repair, as it was an early trial of a rudimentary device. High prohibitive surgical risk patients certainly do well with a MitraClip, and similar to surgery, procedural volume is a key to successful treatment of the MitraClip. The newest generation clip, the G4, as well as contemporary imaging, really allows us to treat more complex patients and achieve better results. And what I didn't mention is that currently the repair MR trial is underway, which is, I think, going to be a very thoughtful and randomized analysis in MitraClip versus surgery at patients at intermediate surgical risk. Thank you very much for your time and your attention.
Thank you, Amar. It was a great presentation, and we will entertain the questions maybe after this presentation, or maybe we can just go to all the three presentations on the mitral valve and then have the panel discussion. That might be the best way to do it. The next presentation is going to be the surgical perspective from Dr. Olaf Wendler. He is the chairman of our cardiovascular efforts in the surgical group at Cleveland Clinic in London. And he is going to talk about the coronary artery disease with ischemic mitral regurgitation CABG plus MVR versus PCI and percutaneous therapy. Dr. Wendler.
Hello, ladies and gentlemen. Thank you very much for the opportunity to talk to you about coronary artery disease and patients who at the same time also suffer from ischemic mitral regurgitation. I will present you something about surgical treatment, percutaneous treatment, and how one can make the decision of who of the patients benefit from which of the treatments best. These are my disclosures. Well, as you all know, ischemic disease, particularly on the posterolateral wall, can affect the dimension of the left ventricle, and it also can affect the papillary muscles. And if the papillary muscles are displaced in severe ischemic disease on the posterolateral wall, this results in tethering on the mitral valve. As a consequence, the postermitral leaflet is restricted as central mitral regurgitation occurs, and this also then further dilates the left annulus, the left atrium, and the mitral valve annulus. As a result of the continuing dilatation, patients then develop pulmonary hypertension, which puts more stress on the right heart, and in an extreme form, the right heart will fail over time, and also the left heart affected by the mitral regurgitation will fail. So in an extreme form, patients will suffer from global heart failure if nothing is done at a certain time of this kind of vicious cycle. And as you can all see, most ideal treatment is addressed before you have severe pulmonary hypertension, before the right ventricle and the left ventricle fails. Coming to our revascularization strategies, and also later talking about the mitral valve therapies, you all know that we have a much longer experience with surgical techniques for both diseases. Nevertheless, particularly for myocardial revascularization. We also look back on extensive studies, not only on PCI, percutaneous intervention on its own, but also on comparative studies. And this is the reason why nowadays there are more clear understanding which patients, what kind of disease of patients should be addressed with what kind of treatment modality. As you all know, and this is data from the European guidelines from 2018, the more vessels are diseased, the more diffuse the coronary disease is, the more left main stems are affected as well, and particularly in patients with diabetic disease. This is a domain of surgery. The less vessels are diseased, the less diffuse the disease is, the better the PCI compares to bypass surgery in terms of outcomes. Nevertheless, it is also important to recognize that there are certain kind of surgical anesthetic techniques, patient management strategies, which reduce a better outcome. One point which is important to mention here is that particularly patients with severe left ventricular dysfunction or severe comorbidities need to be optimized before surgery. During surgery, surgery technique needs to be optimized to reduce the cardiac trauma, to complete revascularization, and to also offer arterial grafts, particularly to younger patients of less than 70 years of age. And also it is important to address cardiac comorbidities at the same time of bypass surgery, not only the ischemic mitral valve we are talking about later, but also, for example, atrial fibrillation, left ventricular aneurysms, so that you get the maximum benefit from the surgical treatment options. But it is also important not only to perform an excellent operation, but the patients also have an optimized postoperative course, be it with medical or even mechanical support to get them through the critical phase of early after surgery. Looking at the mitral valve, the strength of the surgery techniques here is, of course, that we have a number of techniques available to address mitral valve regurgitation. So not only annuloplasty, what is the gold standard to treat ischemic mitral regurgitation, but at the same time, if we find a prolapse on the anterior or even posterior mitral leaflet, we can correct this with chordal replacement. We can resect areas of prolapse if that is needed. We can even increase the size of the posterior mitral leaflet if that is needed, and that is the reason why the repair success rates in terms of repeat leakage after surgery are quite low in experienced hands of mitral valve surgeons. Nevertheless, you also know from this work from Ecker et al. Published in 2014 that mitral valve replacement is also seen as a viable option in a patient with ischemic mitral regurgitation. And in this randomized trial, mitral valve replacement patients had excellent outcomes compared to mitral valve repair. However, what is important to note here is that in the group of patients with mitral valve repair, 28% of those suffered from repeat severe mitral regurgitation in the first year after surgery, and that is, of course, data which is not necessarily acceptable for experienced mitral valve surgeons. However, it is also important to mention that if one replaces the mitral valve in this context, one needs to preserve the subvalvular mitral valve apparatus, and I believe that's one of the reasons why in this study mitral valve replacement had such good outcomes. We also know, and this here is data from the STITCH trial, that in patients with even severe impaired left ventricular ejection fraction, here patients with an ejection fraction of less than 35%, who present with coronary artery disease and moderate to severe mitral regurgitation, surgery is stronger in terms of outcomes than medical treatment. However, and you can see this here in this slide, when you look at the long-term outcomes of patients, and this is 5-year outcome data after a treatment, only if you address the mitral valve and these patients undergo bypass surgery at the same time, and this is the green curve, only then you achieve significantly better outcomes than medical therapy. If you do not address the mitral valve and ignore the mitral valve, which is not always severe in these patients, but also had been moderate in some patients, then your outcomes are not much better than medical treatment. So it is important that in patients with ischemic mitral regurgitation, the regurgitation is addressed at the time of revascularization. Of course, for transcatheter mitral valve repair and replacement techniques, there's much less data available. On the right side, for the Tendyne device, this is currently the only device with a CE mark, and not much of information is available how it compares to mitral valve surgery in this kind of complex patients. However, for the MitraClip, there's much more data available and also comparative data available to mitral valve surgery. The MitraClip is used on the mitral valve in the way that it has fixed the anterior mitral valve, posterior mitral valve leaflet together in an edge-to-edge repair technique, as you know from previous publications. When you look at this review of studies where the MitraClip is compared to surgical repair for mitral regurgitation, what comes out of all these trials is in the end that the MitraClip the group of patients has a higher risk profile. They often have higher age and lower left ventricular ejection fraction. In terms of survival, surgery and the MitraClip are relatively similar, but one big difference between the two groups in the time after the intervention is that recurrent mitral regurgitation is 4.8 times higher and more often seen after the MitraClip compared to the surgical cohort. And as you know, recurrent mitral regurgitation is a very strong predictor of inferior outcomes in the long term. So the real question in the end comes down to which patients with coronary artery disease and concomitant mitral valve disease really face high risk for surgery, because only in these patients the compromise on the mitral valve repair would be really justified. So in principle, one can say that patients have general risk factors, frailty, often they can be immobilized, or they have severe comorbidities, which gives them a high risk for surgery, or they have cardiac factors, something like diffuse coronary artery disease, left ventricle, right ventricular dysfunction, severe pulmonary hypertension, calcified mitral valve rings or ascending aortas, or they have otherwise surgical, challenging surgical access, which increases the risk of surgery. However, most important to assess patients with combined disease on the coronary arteries and mitral valve is maybe to have a proper team of specialists who are able to deal with various patients, not only in terms of high risk, but also in terms of the comorbidities of patients. Because as you can see here between patient A and patient B, patient A is maybe a very straightforward patient for surgery with not much of comorbidities, but diffuse coronary arteries, diabetes, and the mobility will put this patient particularly in a low risk profile cohort of patients. Whereas on the right side, patient B, an 85-year-old female, impaired in mobility, but on the other hand, maybe with not so severe diffuse coronary artery disease, may be an ideal patient for a compromise on the mitral valve treatment. And therefore, it is important that one discusses these patients in a team of specialists who can properly use their expertise to optimize patients before surgery, have then a proper assessment how patients present before for an operational, surgical or interventional strategy, and then also if one of the two strategies is performed, and after that surgery can also as a team provide optimized post-operative, post-interventional care. With this team in place and with the full armamentarium of treatment options in place, one will be able to identify the most optimal therapy for individual patients. Thank you much for your attention. So, ladies and gentlemen, you have heard these two talks. You have seen that on the program we had a discussion break planned, but on the other hand, because the next talk by Dr. Kapadia, the chairman of the cardiology division at the Cleveland Clinic Foundation in Ohio, because his talk is on the secondary mitral regurgitation and different treatment approaches, we thought to bring you this talk now and then have a discussion later on the three talks, the two you have heard, and his talk in the end. So enjoy the talk by Dr. Kapadia, and let's discuss everything later.
Hi, this is I'm Samir Kapadia. I'm the
Chairman of Cardiology at Cleveland Clinic in the main campus. And thank you for inviting me for this very important subject to talk about the functional mitral regurgitation. What are the percutaneous options? First and foremost, when we start with functional mitral regurgitation, there are important things to keep in mind. The treatment of functional mitral regurgitation is a heart failure treatment management. And you have to treat the underlying problem. The underlying problem includes atrial fibrillation, conduction abnormality, coronary artery disease, and optimal guideline-directed medical therapy. If you're still symptomatic with mitral regurgitation, then only you consider percutaneous therapies. So treat the heart failure, and if the heart failure persists and MR persists, then you treat them. Different types of FMR, we will talk about this, clinical significance, how severe FMR is, and what are the treatment options. Very important to recognize that the mitral valve is the atrium, there is the annulus, then the leaflets, then the cords, Pepper muscle, and the left ventricle. All of these are very important for the ultimate function of the mitral valve. And so you have to analyze everything, and most of the people can analyze the annular motion, the leaflet motion, the restriction. The annular is very important because it has three different motions in system. So there is an anteroposterior contraction, the annular height and saddle shape increase, and then there is also a translational motion during systole. So this is the threefold picture of the annulus. So it beats like this, moves, and folds. So this is a very important part to keep in mind. So when you look at the secondary mitral regurgitation, the disease is of the left ventricle or the left atrium. That was the definition, functional or secondary mitral regurgitation. This is by Pat O'Gara. What I say, the secondary mitral regurgitation is a disease of the left ventricle and or, so not necessarily just or, the left ventricle and left atrium, or either or, and or mitral annulus, neither of the two, but mitral annulus, without adequate compensatory changes, because in some patients, the mitral leaflet elongates with functional mitral regurgitation. If the elongation is not enough, that's when you have mitral regurgitation. So this is again an important part to keep in mind. What is the clinical significance of FMR? Now this is very important, simple. So there is a severity of mitral regurgitation, LV dysfunction, and LA dysfunction. So there are some patients who have severe mitral regurgitation, but do not have that much LA dysfunction or LV dysfunction. These patients benefit from treating mitral regurgitation. The other patients who have severe mitral regurgitation, some LA and LV dysfunction, but still have severe mitral regurgitation. So this patient may or may not benefit depending on how severe is the LA and LV dysfunction. And finally, there are patients who do not have very severe mitral regurgitation, but who have more severe LA and LV dysfunction. So this is MITRA-FR kind of patients. So this is also important to keep in mind that those patients typically may not benefit from treating just mitral regurgitation. And how the progression happens, it still remains unclear, and this needs to be studied. This is one way to analyze this situation, is called disproportionate MR. Again, what it says is that the LV and diastolic volume versus EROA. So how bad is the LV function? How bad is the mitral regurgitation? So if the LV function is bad and mitral regurgitation is also bad, then you do better. If mitral regurgitation is worse, then even better to treat the mitral regurgitation. But if the mitral regurgitation is not as bad, but LV dysfunction is bad here, then you don't do well. How severe is FMR? Again, there are several different guidelines, and I'm just pointing out Dr. Zogby's paper. This is a very important guideline document to say that there are many different ways to calculate, but it is not one simple index. It's not just EROA. So you have to keep in mind that there are many different ways, and there are a lot of different criteria. So this is why I made it larger to say it is not just EROA, but A dominant, depressed flow in the pulmonary veins, and how you measure these things. More than anything else, judging the severity is an art. So you have to know the history, you have to know the anatomy of the valve to say that if it is severe or not. The Doppler means the function, the LA size, LV size, RV size, RV function, and more than anything else, also response to exercise and treatment. So all of this has to be taken into consideration when you're judging the severity of mitral regurgitation. What are the treatment options? So the treatment options are clear, that you have to give proper medical therapy. So, the ACE inhibitor, the RNA, the beta blockers, the mineralocorticoids, the isodiazole dinitrate, the ICD, and the CRT. All of them decrease the mortality anywhere from 15 to 40%. However, the surgery for FMR is still considered a class 2B indication. So recommendation is class 2B, level of evidence C, because there are no randomized trial comparing surgery to all of these things that we just mentioned. So what is the current landscape? So MitraClip is approved and MitraClip is available in the United States for these purposes. But then if you look further, you will see that there is not just MitraClip, but you have the Carillon device, you have the spacer, the Pascal device, and there are several TMVR devices that are also available in this particular field. Millipede and Cardioband are doing pivotal trial, feasibility trial, and there are several different devices that are being investigated in early feasibility trial. And there's a huge investment in this. There are 4 sizes of MitraClip that are available currently. And this is called the G4 because they're NT and XT, large size, small size. And just again to keep in mind that they're 15 millimeters versus 18 millimeters length, total length on 9 and 12, the grasping arms. 2 studies that are very important to recognize, the MITRA-FR and the COEP trial. This is the COEP trial we did in the United States. This is the trial MITRA-FR that done in France. What important thing is that compared to MITRA-FR, the COEP trial showed the benefit in death and heart failure hospitalization, both of them, whereas the MITRA-FR did not. Very important to recognize why there's a difference is because how the patients were selected, whether they were optimized guideline-directed medical therapy, whether they had more of mitral regurgitation and less of LV dysfunction, and how good were the results of MitraClip. So all of these are important to determine this. I'm going to show you one case so that we understand what it looks like. So 68-year-old guy with coronary artery disease, hypertension, hyperlipidemia, paroxysmal AFib, CKD. And if you look at this patient, there is significant mitral regurgitation, as you see. And it's important to recognize that you can check this mitral regurgitation by the total, how far it leaks. So ventricular side view of the 3D is very important because you see here that there is a space right there in the middle. And if you can see in the atrial side, you will many times see this kind of this is not a flail, but this is just a slightly degenerated leaflet because it's under stress. And nowadays you can study the details with different kinds of views, glass view, this thing. Now you do a 3D MPR. MPR is a multiplanar reconstruction, and you will plan that this is where you want to put a clip. So the green plane is where you would want to put a clip. So this is the leaflet, this is the leaflet size, how the leaflets are touching, where it is in the medial and the lateral side. And then you decide that this is the right place to put the clip, then what clip will be better? Sometimes you use NT clip, sometimes you use the XT clip, and this is a very interesting and important way to decide, and maybe more than one clip or XTW clips. This is a little bit of an art there to decide, but what we ultimately want to do is to put the clips close together, do not deform the valve, and create a complete closure of the valve without causing mitral stenosis. So if you put the clips very far away, you will create mitral stenosis because the valve will not open. With that in mind, trying to advance sorry about that. And so this is what you see, the final result of this patient. So after 2 clips, you will see that there was a significant mitral regurgitation. Now there's very little mitral regurgitation, but if you look at this from the ventricular side, so this is the top is the atrial side, the bottom is the ventricular side, very little leak is left on the slightly on the lateral side. But as you can see, the clips are very well placed, the valve is closing properly. This is outstanding. So what is the take-home message? Take-home message is that the FMR is a complex disease that requires very careful attention to the clinical part, echo, and what are the options for therapy. Appropriate patient and therapy selection can potentially alter not just how patients feel, meaning symptomatic relief, but also how long and how well they live in their life. So thank you for your attention, and I'm happy to take questions.
That was a great presentation, Samir, and impressive to see how transcatheter technology for mitral valve repair is progressing, and I'm pretty sure that will make differences to the future and prevention of repeat regurgitation then after implantation. Maybe
can we bring all the people on the panel on the video back and also unmute them? Because Bernard is there, Ahmed is there, and Mohammed Trana is there.
That's a very good idea.
Right, because then we can all chat and discuss. So this will be, and Amar is there too.
I wanted to ask you one question, because there hasn't come another question through at the moment, and that is, I mean, you have this the X2O, this new technology, and to repair transcatheter with transcatheter technology, repair the mitral valve. But you also have an extremely well-recognized mitral valve surgery program at the Cleveland Clinic. A lot of these patients even have minimally invasive procedures and less of trauma from their cardiac procedure. So how do you decide which patients you place into the transcatheter groups? How do you decide against surgery? Is that so in collaboration with your surgical partners?
Right. So the first and foremost, of course, we work very closely together. So every week on a Friday, we discuss all the patients for mitral valve, Amar, myself, and we also have our surgeons. So Dr. Patterson, Unai, Faisal, Bakin, Doug Johnson, we all work together. So we all join for the meeting. We have an agenda. So all the transcatheter patients that we do, we put it on the agenda. We go over these patients and then decide together that what we think is the best option. Most commonly, these are extreme risk patients, extreme risk that our surgeons feel uncomfortable operating, or they think that the percutaneous option should be tried first. Most of these patients who have functional mitral regurgitation are the patients that is nobody really wants to operate, because it's a tough kind of a group, and the degenerative MR mostly are very old people with a clippable valve. So if they have an anatomy that is clippable, then we feel good about it. Now we also have several trials that we are participating. So whenever we have a patient that is appropriate for a trial, then we obviously try to see if the trial is appropriate for the patient. And that is how we have been dealing with. But you are absolutely right that this is totally a heart team approach. As Amar mentioned, that for the young patients with degenerative valve disease, we are definitely not doing any mitral clips. There is a repair MR trial. We have not yet enrolled a patient, which is a trial where you will randomize the patient intermediate risk to surgery versus clip. And this particular trial, we have not yet randomized a patient, but we are, if the patient comes, so that one of the parts of the puzzle is also the patient. So the cardiologist, cardiac surgeon, and the patient, all of them are very important, because many times the patient comes with an expectation and they are not even agreeable to having an open surgery. So this is another piece that we have to deal with, because this is the real, this is right now the reality of times, that they will say that, okay, I went to New York to such and such person, or I went to Los Angeles, and now I'm coming here because we want to have procedure here. They already told me that they can do the procedure like this. Why can't you do it? So this is and then we present our surgical side, our transcatheter side. So this is the consumer also is a very important part of the puzzle. And we try to do what we think is the best. So most of the time we do not succumb to the pressure from the patient. If we think that this is the right approach, is to treat them surgically or percutaneously. And it happens both ways. So these are and radiation heart disease, for example, terribly difficult area for us to treat, and we get a lot of patients from everywhere.
Sure. No, that makes all sense, and I also have seen that there was a question from the audience, and Bernard Prendergast has dealt with it because he was a little bit not so focused on the subject we just discussed in the last talks. But thank you much, Bernard, for that. I mean, when you talk about functional regurgitation, of course, we need to remember functional does also include ischemic. In that respect, Bernard, do you think there is a good reason why we should distinguish very clearly between ischemic functional mitral regurgitation and non-ischemic functional mitral regurgitation?
So I think in terms of the end result, the MR itself, the distinction is not so useful. The question really is, does revascularization have an adjunctive role? And we don't really know completely. You covered this very well in your own presentation, and the data from the Stitch trial and others leaves us with quite a lot of questions that remain unresolved. And there's very little data to tell us what to do in terms of angioplasty as an adjunctive treatment, for example, to edge-to-edge repair. So I think it's a very difficult area, and we don't have all the answers. I think we've just got to judge it by ischemic burden in individual patients, and what anatomy is treatable. What can we fix, in a sense, determines what we should fix.
But I think your point is very...
to that point. Sorry, Dr. Kapadia.
No, go ahead, please.
To dovetail, and by the way, good to see everyone. To dovetail to Bernard's point, I think it's very important to understand whether there is coronary revascularization that is possible in these FMR patients. So, of course, all of these patients we analyze have a coronary angiogram, and if there's LV dysfunction, we send them on for the default in our places to do PET scanning for viability. And so if there are opportunities there to revascularize, viable or ischemic myocardium, whether that is feasible by way of PCI, that might be the right strategy for somebody with a low LV function and FMR, or if a surgery is necessary, that's also something that our surgeons will consider. But we try to make sure that if our plan is to proceed with a MitraClip on the background of comorbid conditions, we always revascularize them first if we can. Our EP colleagues are also on that team meeting that Dr. Kapadia mentioned to say, are there roles for atrial rhythm management or CRT implantation and so forth? Because I think that kind of totality of treatment is important for these patients.
So one question I wanted to ask you, and this is an important question, is that, so in the COAP trial, the ischemic and non-ischemic were not differentiated, right? So they were end-stage heart failure patients, so they were treated. As surgeon, you would say that the patients who have a scar in the inferior wall versus the patients who have a dilated heart from a cardiomyopathy are different. Anatomically, they're different. The strategies that how much annulus is dilated versus how much the restricted leaflets are to the apex are different. Currently, our treatments for the MitraClip is just MitraClip. So there is only one part of the area that we are treating. So I cannot agree more. And in the MVARC, we are trying to make this distinction to say that we have to have a proper understanding of the anatomy when we are treating this patient, very similar to the aortic valve, before we say that functional or whatever terms we want to use. So that's why the new guidelines came up with primary and secondary. I hate that term because secondary mitral regurgitation is secondary to something, right? If you have a leaflet prolapse, that's a secondary. It's not what is primary. And annulus is part of the mitral valve, cords are part of the mitral valve. So it's very hard to call something primary versus secondary. But doesn't matter. The functional mitral regurgitation, I think, should be separated very carefully into the coronary artery disease related, meaning ischemic, and even ischemic as part of ischemic versus scar related. So these are very crucial parts. As a surgeon, people ask this question all the time, and I think it is a very important question for even a cardiologist referring a patient to understand that what is the mechanism of this mitral regurgitation? What are the parts that are deranged?
So for surgeons, of course, I mean, that's what you ask yourself as a surgeon always when you have someone with an impaired left ventricular function. Is there something you can do to improve the left ventricular function? And of course, in that respect, if you have territories which are viable and revascularizable, where you have active ischemia beforehand, then I think that is maybe an option. We have only a few minutes left, and that's the reason why I would like to ask our colleagues in Abu Dhabi. So how is the MitraClip therapy option taken by patients over there and physicians?
Ahmed can give a definitive, answer as to the utility of it. So the cultural hesitation to have anything done open here is extreme. There's no doubt. But I think the biggest problem that we face is the dysregulation or the unregulation of the system. So I totally agree with Dr. Kapadia, is that we adopt the same philosophies, that we'll recommend to the patients what we feel is the best for them, but there's a great deal of resistance. And often, we'll deal with people who have gone off to another institution where, a cardiologist or a surgeon has phoned the vendor, gotten their hands on a device and, done that device with a remote proctor from somewhere else in the world. And it just be a purely commercial driven procedure. And that's really the biggest challenge we face, because once it goes sideways, of course they come here. Right?
I mean, I'll add, Mahmoud is leading our program, but I think we have to realign, what the expectations of the patients, but also I think our job in not only teaching the patients what to expect, but also the community at large. There's a huge gap in terms of knowledge, not only in the Abu Dhabi, but in the United Arab Emirates total, and sometimes even the region. We're referring young patients for MitraClip inappropriately. But again, we're realigning the patient's expectations and understanding, and also the physicians in the community. But I think that's very important for us to do, and our main utility here in the UAE.
And I think that is a very nice comment to the end of this webinar today, in the way that, from my point of view, I agree completely that there are so many treatment options available. It is important in these days that healthcare organizations like the Cleveland Clinic have comprehensive teams, comprehensive access to different kind of treatment options, be it transcatheter options, be it surgical options, but be it also the ability to talk to each other and approach certain kind of disease aspects, be it the heart or somewhere else as well in the body, together as a group of physicians and surgeons, interventionists, imaging specialists, so that actually you put yourself in a position to identify the most suitable kind of procedure for individual patients, and therefore satisfy the patients and their needs appropriately. With this, I would like to thank all my colleagues from the Cleveland Clinics for their participation in this webinar today. I would like to thank the worldwide audience for their interest in the presentation from today. I would like to make everyone aware that there is some more to come. There is a webinar on the 4th of April on vascular disease. There is one webinar on the 11th of April this year on heart failure management strategies. And I would like to invite all the participants from today and their friends and colleagues who hopefully will hear all the good news about this webinar to join us in the future. With this, all have a good Sunday evening and rest of the day on Sunday on the North American side, and see you again in the future. Thank you.
Thank you. Thank you again, Olaf, Bernard, Amar, Ahmed, everybody for joining. Gopal, thank you again. Thanks, Mohammed, for organizing. Trainer.
Thank you, everyone.
Thank you, everyone.
Thanks. Bye.